So should we start, sir?
I don't know who is more. Yash, where is Yash?
Yes, sir. Sir, we'll start, sir. Good evening, sir.
Yeah, good evening.
डॉक्टर सप्रा सर, डॉक्टर जिरपे सर, आप लोग स्टार्ट कर दो आज.
ठीक है सर.
No, we have to start or you will
मैं
start?
I'll announce
You
and
have
sir,
to
then
do
we'll
the
start.
announce, sir.
Okay, okay. So first there will be the just I will give the theme and then I will hand over to the Dr. Harsh, right?
Yes, sir. Yes, sir.
Okay. Shall we
We are
start?
live, sir. Yes, sir.
Yeah. Yeah. Welcome you all. Good evening. Every year on the 22nd of March, we observe World Coma Day. And it is under the curing coma. It is not. It is like a curing coma. This theme was started by the Neurocritical Society USA or the parent branch. And the entire concept of the curing coma is save those lives who are with the coma. So coma is not a social stigma. Coma is not a irreversible. If there is a irreversible coma, it is a brain dead. It is completely unplugged with the coma. Please don't confuse the brain dead with the coma terminology because that's what the major mixing in the Indian scenario is happening, and we are facing a lot of issues like that. So today is a curing coma. The word itself says that the what is mean by the curing. So every coma there's a chance of the reversibility. Every coma, there's a chance of the life. Every coma, the patient can go back to their near normal life. And on that background, in 2020, they come up with the Curing Coma campaign. And on the that Curing Coma campaign, the main purpose of this activity is to promote the diagnosis of the coma aggressively. One need to aggressively face the coma and its diagnosis and try to get those victims as early as possible out of those crises. And now what they have come up to the curing coma campaign, don't use the coma terminology. They say use the disorders of the consciousness. That means the unconscious, vegetative, locked in. There are various terminologies we have now established. So coma is very negative. We can say the disorders of the consciousness, and under that terminology, try to head the coma in a very positive aspect. We need to see the coma with the positive aspect, and for that we need a lot of research. The second aspect of the curing coma campaign across the world is promote research in the field of the coma, promote research in field of the diagnosis, promote research in field of the management of the coma very effectively, and try to get those victims near normal life as early as possible. So what is this campaign? This campaign during this day, 24 hours, and throughout year also we published this NCS published a lot of case reports. They do the webinars. There are the videos get uploaded. There are various activities goes. There is a lot of funding get raised. That is what the curing coma activity. And as a SNCC, as a Society of the Neurological Care India, we take the participation in curing coma campaign. With this background, I hand over to the Dr. Harsh, who is a chairperson from today's webinar. Harsh, over to you.
Good evening, everyone. So, Curing Coma campaign is an initiative which is run by the SNCC, which is the primarily started by NCS US, and we partner with them for this Curing Coma campaign. Our previous leaders, Dr. Himanshu, Dr. Zirpe, have very actively followed this Curing Coma campaign and have had lot of papers and lot of publications with the NCS regarding this. So coming on to coma, it is a dynamic neurobiological state demanding urgent definition, localization, and reversibility assessment. So it is not just the prediction, but also the precision to secure physiology, identify mechanism, and protect the vulnerable brain. So obviously we have two very prominent speakers today on this panel to speak on the coma perspective of the World Coma Day. And without taking much of your time, may I welcome Dr. Siva Kumar to give the welcome and the introduction to the significance of Coma Day. and then Dr. Vasudha to talk on understanding coma beyond unresponsiveness.
Thank you,
First,
sir, and good evening to everyone. And outset, I'd like to thank SNCC for this opportunity. Between mine, Jirpe sir, and subsequent speakers, there will be a bit of overlap. Please bear with us. Some of the key aspects will be repeated for reinforcement, and I'll be just discussing about the significance of this World Coma Day in the next 5 to 6 minutes. The first and foremost importance of this World Coma Day is to create awareness. As we all very well know and discussed by the previous speakers, coma is a very complex medical condition, and we have not very well understood this condition. And thanks to the media and many movies, there is a lot of misunderstanding, misconceptions, and stigma attached to coma. And these kind of awareness programs will help to dispel these myths and misunderstanding. That is the first and foremost purpose of this World Coma Day. The second is to educate. I think the key aspect of this whole commodity is to educate, and this education should encompass the clinicians, the patients, and their families. The clinician should be educated that coma is a spectrum, and probably that will involve patients who are in a vegetative state to patients who are in a minimally conscious state. The clinician also should be educated. The patients who are deeply unresponsive may have some amount of awareness. So these things should be educated to the clinician. The patients and their caregivers should be educated to prevent as much as possible, to understand the early signs of coma and when to seek help. So this is the another aspect of this coma campaign. The next, the purpose of this World Coma Day is to highlight the role of medical care and research. As Jirpe sir rightly pointed out, there are a lot of advancements in neurosciences and critical care. This has contributed in a larger way to betterment of these coma patients. On this Coma Day, we should encourage continued research funding and innovations in the field of coma. The next, the key aspect is the global research. I think the organizations like neurocritical care societies across the world, the institutions, clinicians, researchers, support groups, they all should come together. They should share their knowledge. They should share their experiences. They should share their best practices and their research so that it helps in overall improvement in the patient outcomes. The next purpose of this or the significance of this World Coma Day is to recognize the patient, caregivers, and their families. Behind every coma patient, we all will agree there is a family which goes through various physical, emotional, economical, and social challenges. It is their dedication, determination, and resolve which gets them over this. So these families needs to be recognized. They need to be supported through various support groups, and this is one of the other purpose of these campaign. The last but not least is the to promote hope. These World Coma Day also promote hope. We all know that there are a lot of surprise stories, and there are many patients who do well despite the challenges and surprises. And these surprise stories tells us that brain is a very resilient organ and is not fully understood. So these are some of the aspects of this campaign, and probably I would like to end up saying that the awareness is important, and probably this leads to better understanding, and better understanding leads to change in practice. So let us use this day to educate ourselves, support affected families, and advocate for better care and research. Thank you.
so very precisely driven points, Dr. Sivakumar. So I would request Dr. Vasudha to take the next talk, please.
I hope my slides are visible.
Yes.
Okay, so good evening, everyone. And we are going to talk about an important aspect of coma today, beyond unresponsiveness. What does this topic basically mean? classically the bedside assessment of any unconscious patient, the so-called comatose patients, has relied largely on motor responsiveness. So, what I'm going to discuss in the next few slides is the concept of moving beyond responsiveness to examine coma through the lens of modern neurobiology. Okay, so talking about the neurobiology of consciousness. Now, consciousness is basically two components: arousal, which is wakefulness, and awareness, that is
I
content.
think
To
somebody's audio is unmuted. May I request everybody to mute their audios, please? Continue, ma'am, please.
Okay. So we were talking about the neurobiology of consciousness, which consists of two components: arousal, that is wakefulness, and awareness, that is content. Basically, together they form the components of consciousness, where arousal provides the on state and awareness provides the content of thought. So, arousal is a physiological state, awake or asleep, and awareness is the cognitive content. Now, both of these are governed by different pathways. Arousal or wakefulness is primarily governed by the ascending reticular activating system in the brainstem and the thalamus. Awareness or content is through corticothalamic networks and frontoparietal connectivity. So, there are a lot of networks that are involved. Important thing is that these networks, these network connections, they are bidirectionally connected because both feed forward and feedback response processes are necessary for a conscious experience. So, as we understand, consciousness is equal to arousal plus awareness plus network integration. Now, based on all of this, we would proceed with how the definition of coma has evolved beyond responsiveness. So, traditionally, coma is a state of profound unresponsiveness characterized by the absence of both wakefulness and awareness. So, this is the traditional definition, which is actually a binary model: conscious or unconscious. So it reflects coma as an endpoint, but the binary model is basically fundamentally flawed because not all unresponsive patients are unconscious. And how, I would let you know. What is the problem with this definition is at the bedside, our assessment of consciousness depends almost entirely on motor output. So we ask the patient to open their eyes, move a limb, or follow commands. But what if the brain is understanding and the body is not responding? And that is the question. So there are studies which suggest that up to 15 to 20% of patients diagnosed as vegetative may actually have some level of consciousness, which means what we label as unresponsive may not truly be unconscious. And that is a critical gap in our understanding. So, what we understand now with the modern concept is that coma is a continuum of disorders of consciousness. Dr. Zirpe also talked about it. Consciousness basically exists on a spectrum. These are not fixed categories. So, as we can see in this, there is a state of coma which may progress to a vegetative state, which is also called unresponsive wakefulness syndrome. So, the patient may be wakeful, but there is no awareness. Then it may proceed on to minimally conscious state, where the patient may be partly wakeful and partly aware as well, but in spurts, not very consistent. And then that may progress on to emergence or normal consciousness. Now, these are not fixed categories. The patients may fluctuate, sometimes within the same day. They can improve, deteriorate, remain in intermediate states. So, a coma basically is not a single point. It is a kind of a moving target, a kind of a dynamic continuum, what we say. So, to understand all of this better, we need to separate what we see from what is actually happening. And this is what we call phenotypes and endotypes. Now, what is phenotype? Clinical phenotype is what we observe at the bedside. No response, no reflexes, minimal movement is what we classify as phenotype of coma. But an endotype is actually the underlying mechanism, what is happening inside the brain. So, I'll give you an example. So, two patients will look identical clinically. Both may appear to be deeply comatose, but one may have a reversible metabolic suppression, the other may have an irreversible structural brain injury. So, both of these have different endotypes, but a similar phenotype. So, completely different biologies and therefore completely different outcomes. And this is the importance of endotyping of coma as well. Now, the game changer here is the cognitive motor dissociation, one of the most important concepts that has come up in recent times, and that has actually changed the entire paradigm of coma. So, what is cognitive motor dissociation? These are patients who appear entirely unresponsive. So they are unresponsive, they do not move, they do not speak, they do not follow commands. But when we use advanced tools like EEG, or a functional MRI, we see something remarkable. So I'll give you an example. When asked to imagine playing tennis, this is what I've written in my EEG paradigm. So imagine playing tennis, or imagine walking through your home. So their brain activates in specific reproducible patterns, which means they heard the command and they understood it and they followed it as well, but without any visible movement. So the brain is conscious, but the body cannot express it. So this is called covert consciousness. Clinically unresponsive, covertly aware. So from other states, if you try to differentiate, there is no there is awareness present in CMD, but the motor response is absent clinically. So best understood as a network disconnection disorder. So there are intact cortical processing where awareness is preserved probably, and the output pathways like motor cortex, so thalamocortical circuits, all of them are impaired. Now, there has been a lot of work on the CMD. I have highlighted a few of them. Jan Klassen et al. This is the group in Columbia University who've done a lot of work on CMD, published their work since 2019 onwards. And they said that brain activation in response to spoken motor commands, they can be detected by EEG in patients who are clinically unresponsive. So basically, the further studies, all of them were from the same group actually. And they said that presence of covert consciousness can reliably predict which patients will have a meaningful recovery. Now, the question is, why do we miss it? We are limited by what we see, actually. Our bedside exam is fundamentally limited. So why? Because it depends mainly on motor output. But motor pathways may be disrupted even when cognition is intact. Add to that fluctuating arousal, sedation, critical illness, and it becomes easy to underestimate unconsciousness, consciousness actually. So this is why we need a multimodal approach, combining clinical examination with EEG, functional imaging, advanced paradigms basically. So because what we see is not always the full picture. How does that impact us clinically? The implications can be profound. The diagnosis may go wrong. The prognosis may change. Decisions about care, especially withdrawal of life support, all of that can be affected. Rehabilitation planning, communication attempts, all of these may change. So, based upon all of this, my take home message today is absence of response is not absence of awareness. We should be aware of the different conditions that are involved in coma endotyping. Coma is not an endpoint. The diagnosis requires multimodal assessment, clinical, EEG, functional imaging. Basically, coma is dynamic, one that demands a deeper and a more nuanced understanding. So this is a spectrum, a continuum that we see. So the next time we encounter a patient who does not respond, we must pause before we conclude, because absence of response is not absence of awareness. Coma is a spectrum driven by different mechanisms, different trajectories are there, different possibilities for recovery. So our challenge basically is not just to examine the patient, but to actually understand the brain behind that silence. So when we move beyond responsiveness, we move close to better care. Thank you so much. I hand over to Dr. Sapra.
Thanks, Dr. Vasudha, for the lucid talk. And surely, absence of response is not coma or unresponsiveness. So, that is the point the coma campaign wants to drive in. And obviously, to create this multimodal approach and the phenotyping of coma. So, let me get on to the next topic and invite Dr. Sautik Panda to talk on neuroprognostication in coma. I would request him to introduce his panel, and we can start with the panel discussion.
Thank you so much, sir. Good evening, everyone. Just give me some time so that I can upload my slide, and the host has to allow me to share my slide, please.
Dr. Yash or Dr. Prashant, I think you are the co-host for the meeting. If you could allow Dr. Sautik to share his slides, please.
Yeah, good evening. Just a second, let me check.
Sure.
Good evening, ma'am.
Hello, sir.
I feel that only we have joined here. Three person.
No, we are here.
All of us
Prashant
are here,
boss.
Dr. JP. All
Yes,
of us
sir,
are
we
here.
are live.
We
We
are
are
there.
live, and there are everyone is here.
Everyone is here,
Yeah,
and
we are
we
starting
Okay.
the
are in
panel
the
discussion.
we are in the middle of the panel discussion.
I hope my slides are visible now.
Yes, they are.
Yeah.
Kindly.
Thank you so much once again, and taking things forward from here. So now we are going to start a panel discussion, and I think Sharmili Madam is busy in another conference, so she will be joining sometime very soon. And we have the other panelists with me. So today we have Dr. Suresh Ramasubban sir, Dr. Urvi ma'am, and Dr. Gaurav. And the topic, as you can see, it's about neuroprognostication in coma. And let us start because we are all very fond of reading definitions. So this is a very working definition for neuroprognostication, that it is nothing but the prediction of neurological recovery after coma due to acute brain injury. And it applies to all these conditions like post cardiac arrest coma, following a traumatic brain injury, following stroke or toxic or metabolic encephalopathy. So why this topic matters, as has been discussed by my earlier speakers, particularly Vasudha ma'am, that it actually impacts the survival and disability outcomes. And this is a high stake decision zone because when you are prognosticating somebody in a state of coma to other family members, so this is something that is really going to change the family dynamics. So that's how it becomes very, very important that you are absolutely sure about what you are talking about. And it is going to determine whether you would like to continue or whether there has to be a withdrawal of care from the family side. And this involves some major ethical and emotional implications as well. And as I told you, that it has to be a very tight walk on the rope, and there are chances of prognostic errors. Particularly, there is a high risk of self-fulfilling prophecy, so one has to be very, very careful while prognosticating a case of coma. So moving ahead, this will be my first case. I have titled it as the quiet storm because we have all faced this kind of clinical scenario in our day-to-day critical care practice. So here is a patient who is a 45 years old male. He has been a known case of type 2 diabetes mellitus, hypertensive, dyslipidemic. He came to the hospital emergency with a history of precordial chest pain for last 2 hours with radiation to left shoulder. Soon after arrival in the emergency, while the initial evaluation was going on, he had a cardiac arrest. The arrest rhythm was ventricular tachycardia followed by ventricular fibrillation. So CPR was done as per ACLS protocol and ROSC was achieved after 20 minutes. So the post-arrest care was given in the ICU with active temperature control to 36 degrees centigrade, and other supportive relevant care, they were all given with elective mechanical ventilation was continued. And currently it is 48 hours post-arrest. Today is day 2. He is off sedation but remains in a deep coma. His GCS is E1 VTM2. The pupils are sluggishly reactive. So I'd like to put forward the first question to Dr. Suresh sir. What is the proper timing, or what we can say as the golden window for the clinical assessment or neurological evaluation in these kind of post cardiac arrest scenario in order to avoid premature prognosis?
Thanks, Shotik. As you rightly said, it's a very standard care. I would like to ask whether, one of the things that also makes a change in our decision making is when somebody comes into the VTV, if irrespective of their mental status, we would have probably gone into the cath lab and shot a dye and see whether there's something reversible or not also. So if that is done, then obviously the outcome and the prognostication, we are a little bit, when we have done the real etiological if there's a culprit LAD lesion or something which you have stented, and then it becomes a completely different ball game as compared to somebody whom we haven't done. That's one aspect of the picture. That's not the entire aspect. The general rule after cardiac arrest has been what we call as, I was always told, as the rule of six. That means you wake up, 90% of the patients wake up at 6 hours. The remaining 10 of the remaining 10%, 90% will wake up in 6 days, 6 weeks, and 6 months, and so on. But by most of the people post cardiac arrest should wake up immediately. So what is the golden time, especially when you do targeted temperature assessment, you have done sedation, you need entire washouts of the metabolic parameters. We would strongly say nothing less than 72 hours. So at 72 hours is what is the golden window where you would say, especially if their temperature is corrected, their metabolic parameters are now corrected, their hemodynamics is now stable. And that's probably the point at which we should do it.
Okay, right. Correctly said. I just like to deviate from the main topic, and I'd like to highlight this particular guideline, which has been updated last year itself. This is the SSCHA CPR guideline 2025, and as you can see, that active temperature control now has been widened. The range has been widened. Earlier, we used to say therapeutic hypothermia or targeted temperature monitoring of maybe 32 to 34. But now, after the results of the TTM and 1 and the TTM2 trials, that the temperature is now between 32 to 37.5, and the minimum duration is 36 hours. So, what the guidelines for neuroprognostication in comatose adult survivors from the Neurocritical Care Society tells us is that one should wait, as sir has correctly said, that at least 72 hours after the rewarming has been done, and once you have taken care of all these confounders that sir has already spoken about, like sedatives and the paralytic agents, and rewarming has been done, and the metabolic derangements have been taken care of, and if there is any underlying sepsis, so that the sepsis control is also of profound importance. So once these confounders have been taken care of, and it usually takes around 72 hours post the rewarming, then only you start the initial neurological assessment for your prognostication. So talking about sedation confounders, as a critical care person, we are all very aware of the effect of these hypnotic drugs. Particularly propofol, it's a short-acting agent, although then the midazolam, if it's an elderly patient, particularly with a background of liver and a kidney dysfunction, then the effect may get prolonged. Fentanyl, it's a lipid-soluble agent. It moves to the tissues and then redistributes back to the intravascular compartment. So the effect of sedation may get prolonged. Dex is obviously it has got a minimal effect. So these sedation confounders have to be considered properly while you are thinking about the initial level of assessment. So if you look at now, going back to our case, the timeline. So 0 hour, there was an arrest, 20 minutes it took for the ROSC. Remember, it was a shockable rhythm. Shockable rhythm, they always have a better prognosis than non-shockable rhythms. And we did a TTM for 36 hours. And at 48 hours, the patient was still in a coma. 72 hours, we started assessing. So these are the data that we get to see at 72 hours. The peoples are non-reactive. We get to see a burst suppression EEG and absent bilateral N20 in SSAP with a biomarker NSE, that is the neuron specific NOLS elevated. So the core principles is wait for more than or equal to 72 hours, avoid the confounders, and use a multimodal approach, which Vasudha ma'am had already spoken about, and just to avoid early pessimism. Now, this will take me to my next question to Urvi ma'am, that talking about multimodal approach, which one do you trust the most?
Hi, Dr. Sautik, and thank you for inviting me to this panel discussion. But yes, as you have rightly mentioned, that it is not going to be a single mode which will tell us how to prognosticate a patient who has suffered a cardiac arrest and is comatose even at the end of 72 hours. So what I think what most of us do in Indian ICUs is serial neurological examinations when we are reasonably sure that the sedation and the other confounding factors have been tackled. That is one thing. And the second thing is, I think EEG is definitely getting more and more popular. And then there are some malignant EEG rhythms, which when present at 72 hours do indicate the possibility of a poor neuroprognostication. Again, there is no certainty here, so there may be times when you may have to extend your prognostication over the period of next 2 or 3 days. And if your serial neurological exams, the EEG and radiological examination, especially an MRI, the diffusion weighted and flare, or a CT scan, which probably will show us whether it is a neurological event to the existing coma. All of this, when put together, along with your N20 on SSEPs and neuron-specific enolase. I don't know how many ICUs do SSEP and NSEs, but at least radiological examination, presence of malignant rhythms on EEG, and serial neurological examinations after you have tackled all the confounders. I think that's the way, pragmatic way forward. That's what I feel.
Yes, ma'am, you are absolutely correct that it's a multimodal model that outperforms a single predictor. And one should always try to combine everything, all the informations together. So taken from the clinical examination to the neuroimaging to all the electrophysiological data that we get from EEG and SSAP. And then comes the biomarkers. Now, talking about biomarkers, their availability, their cost and turnaround times are definitely an issue in Indian ICUs. And if you can say, what are your experiences about biomarkers in this particular situation, a post cardiac arrest coma?
Is this question directed to me?
Yes, ma'am. Yes, ma'am.
Okay,
Yes, ma'am.
okay. So I think the NSE kit is commercially available now. I'm not sure about the S100 beta, but the NSE kit is definitely available, and you can get values anywhere between 30 to, I think, more than 100. That's the range it comes in. And so if you have done it for patients with post cardiac arrest coma, then there are multiple studies you must have read, and I'm sure the august audience here have been reading through NSEs. There is a wide range of values which have indicated poor neuroprognostication, but I think the common consensus still lies at more than 60 microgram per liter. So if NSE is available, it can become one more ammunition to the entire gamut. But NSE also, another thing is there are more and more reports which say that NSEs, which are very high even on day one, in spite of patients who are undergoing TTM and sedation and paralysis, it is still an indicator of a poor prognostic outcome. So we need to see if NSE is done very early after an event, will help us prognosticate earlier, because right now we have to wait almost 72. So basically the earliest we can prognosticate after a therapeutic hypothermia is the 4th or the 5th day. So people who are paying out of their pockets, the families would be very interested in knowing earlier on whether this is going to make, the treatments are going to make a difference or not. And in that space, I think NSE may play a role.
So do we need a serial estimation of NSE, ma'am?
I'm not sure about that. I don't know what the other panelists feel.
And at what point of time you would like to send the NSE? The first NSE that you would like to send will be after 72 hours from rewarming?
Yes. So after 72 hours, no. At 72 hours, so when the patient has been rewarmed and the confounders have been tackled, that's when the first NSE can be sent, again along with the other factors. That is my understanding. But there are some case reports where the day you put the patient on hypothermia, the same day you can send an NSE, and if those NSE levels are extremely high, it could be an indicator of a poor outcome on day one of the event. So I don't know if serial values play a role. I'm not sure.
Okay. And do you have any experience about NFL, this neurofilament light chain? Are they at
No,
all available in India?
I don't think so. I think NSE and S100 beta, I think they are the only two available. Again, I would like to ask other senior panelists here if they have any experience on this one.
No experience.
Dr. Gaurav?
None at all, actually.
No, so none in either of the two. In India, no experience, and I don't think it has reached any benchmark standards, even in Asia. Probably it's still trying to climb onto the clinical side.
Right. So till date, we are heavily dependent on neuroimaging and the EEG, particularly serial EEG monitoring, is perhaps more important because I'm not sure whether all the ICUs have SSEP also to support us. Not talking about the neuro intensive care unit.
He's still going on about like
So taking things forward, so whatever we have discussed so far, if we can place it in the form of an algorithm, so one has to stabilize and treat the cause, wait for more than equal to 72 hours, stop the sedation, get rid of all the confounders, do a multimodal testing, and that is the key because you cannot just rely on one set of examination reports and you have to combine all the predictors and it has to be more than equal to two predictors and only then you can go ahead with the family discussion. So this is what, again, going back to the same guideline which came in 2023. And this is almost that all we have talked about so far, taking things, just summarizing things together from this guideline. So some of the reliable predictors of poor outcome are like the bilateral absent pupillary reflex for more than 72 hours, bilateral absent N20, and then some malignant EEG patterns. So this is a flare in severe hypoxemic brain injury, and as you can see in the CT image, there is diffuse cerebral edema. Burst suppression is something that we rely upon very heavily during this entire period. And some of the other malignant EEG patterns like status epilepticus and all. And this is an SSAP where there is on day 3 of the cardiac arrest, if you can see that there is no cortical response at all, there is absent in 20. Whereas in follow-up day 9, there is some in 20 evolving out of the cortex. And that brings me to the next question, which any one of you can take, because Sharvili ma'am, I think she has not yet joined. So if there is some kind of a discordance, so if the EEG shows that there is a burst suppression, but the brainstem reflexes that you are checking regularly, they are found to be intact. So how do you reconcile this discordance? And does this EEG alone is going to push you towards a poor prognosis? Any one of you can take this question.
So my take would be to wait, and if the brainstem reflexes are there, but if you've got, unless you've got a very robust serial pattern of bad EEGs, it will have a confounding effect. It will have a profound effect. But a single episode of burst suppression can be, because of drugs, can be because of poor clearance, can be because of a lot of pharmacological factors of the patient itself. So you got to wait, you got to repeat, and you got to give it time. That will be the short answer from me. So you just can't go ahead and do anything about prognostication if you got intact reflexes, but the EEG one off or even twice shows burst suppressions. You got to wait.
Okay, so you just wait to clear the cloud if the clinics are doing good, if the brainstem reflexes are intact, maybe you should wait before you jump onto a poor prognosis. Suresh sir,
No,
your
no,
take on
no,
this
no. Yeah,
question.
yeah. No, no. I think burst suppression, all these things are negative prognostic markers. They are, again, when you say brainstem reflexes are not there, we're talking about brainstem death. We're not talking about poor prognosis from a vegetative state or remaining in a vegetative state or remaining in a comatose state. Brainstem death is a different kind of a little different issue. You can definitely progress to a brainstem reflexes. When we say about neuroprognostication, we're talking about people who remain in that kind of a state for a long time or have no chances of recovery from that kind of a poor, from a coma state. So I think, so burst suppression, again, like in SS20, will all have a negative predictive value, but in the sense, if there is a burst suppression, absence of burst suppression is good, but presence of burst suppression is not going to change my. Yeah, it is going to give me a little negative connotation. But so I'll still go with the clinics and saying that yes, somebody is deeply comatose, still EEG showing burst suppression. It's more than 72 hours. We really need to have a chat about neuroprognostication here.
Okay. Okay, got the point. So coming to the Indian ICU context, so these are some of the things that we have to face regularly. Financial constraint, everything finally boils down to money, and financial constraint is something that we always have to take care of in a comatose patient because we don't know how long he or she is going to take. And there are various cultural expectations, people coming from different strata of the society, out of different cultural backgrounds, and family driven decisions. So these are also very important, and many a times we get to see a divided decision from within the family itself. So that brings me to the next question, and I'll direct this question to Dr. Gaurav. How do you communicate, prognosticate uncertainty to families when the findings are actually indeterminate and the data is gray?
Now, I think that's a routine scenario and that's a difficult scenario. So when you have a mixed picture and you know it's going to take a long time, you neither can you call it quits, neither can you say that this is going to go well. So yes, the financial burden starts to creep in, and we see it routinely when finances are not involved. It goes on, and sometimes you have some meaningful recovery, and most of the times it is not. But the other two parts, I personally try and stay away from the families making decisions, whether it is interference or in other connotations, even so for cultural as well. So finances do become a reality, and you have to adjust to those, because if you have a gray decision, the scenario that you just explained, where you have all reflect brainstem reflexes are intact, but you have a poor prognostication of EEG, you just can't switch off, you just can't call it quits, and you got to wait. But somebody doesn't have the financial power to carry on in an ICU, you've got to explain that it's going to be a long time where the patient is going to be dependent for acute care, and you are going to need alternative decisions, alternative areas for care, and you got to introduce areas, whether they shift patients or they make alternative arrangements at kind of home care settings. So it is very, very difficult in the Indian scenario where finance comes into the picture. If this is another scenario where finance is not into the picture, then this question becomes easy to answer. Then you wait for black and white and you don't wait for the gray part. Uh, Involving the family then becomes important, where you can take shared decision making, and again, it needs to be tailored and individualized to the patient. If somebody is having this with a lot of other comorbidities and the quality of life wasn't great at that stage, it's easy to come to shared decision making with the family. But if things aren't like that, then it becomes difficult.
Okay, so that brings me to the last question of this particular case, and I'd like to ask this question to Urvi ma'am first. At what point do you feel confident enough to discuss poor neurological outcome and potential withdrawal of care?
So see, what I think is there are some clear indicators. So absence of brainstem reflexes is one of the clear indicators. An MRI which shows on DWI and FLAIR images which shows cortical damage, these are clear indicators, right? I mean, there is no ambiguity here. If you have not given therapeutic hypothermia and sedation and paralysis, then you may be able to prognosticate a bit early when there is absence of brainstem reflexes. The EEG doesn't show any of these malignant rhythms, but it shows a non-reactive EEG, and the MRI shows extensive brain damage. So then if you have all of this, then you are more confident in prognosticating as and when you get these reports. So I would rather suggest, instead of thinking about prognostication in a time fashion, I would say that what is the evidence that you have before you want to prognosticate. Like, just like Dr. Kakkar said, if brainstem reflexes are present and there is EG which shows burst suppression, we'll have no option but to wait and find out if we can move away from that gray zone. That's what he was trying to say. So here again, these are very clear indicators that if you prognosticate today, also you are not in the wrong. Now the question arises when these fact indicators are not there, or we are in that gray zone where you have some EEG which shows some reactivity, but then intermittently there are some malignant EEG patterns. You don't have a N20, you don't have an NSE, but your radiological imaging does not show very severe brain damage. You may have to repeat these things, and you may have to kind of come to a overall conclusion that maybe we need to wait. Sometimes you need to wait for 2 to 3 weeks before you can prognosticate and tell the patient's family that, look, we are very sorry, but nothing more can be done for this patient. However, in India, we are looking at multiple other things. So, one is the finance because it is an out of pocket expense. Secondly, is the age and the presence of multiple morbidities that the patient may come with. So, if I have an 89-year-old patient with a out of hospital cardiac arrest, downtime is more than 40 minutes, and even though MRI just shows severe atrophy and nothing else, I would be very hesitant to tell the family to wait and for 3 weeks to decide whether this prognostication is going to be good or not so good. So I think looking at it in the context of what evidence you have, looking at it in the context of what kind of confounders you are going to have, because our treatment will also add to the confounding factor, and the clinical context in which the patient comes to you, all this put together is where I think you can decide that this is the point where I'm going to say this is a poor outcome.
Right, correct. So let us now quickly move into our second case. We're running short of time. So it is about the traumatic impact. Because we are going to talk about the severe traumatic brain injury. So here is a 22 years old female involved in a high-speed motor vehicle accident and was brought to the ER. The initial CT brain showed a diffuse axonal injury grade 2 and relevant medical management was started. It is now day 14 and she has started opening her eyes spontaneously but does not follow commands or fixate. Families are asking if she is waking up or not. So I would like to start again with Urvi ma'am, that how do you clinically differentiate between a vegetative state and a minimally conscious state in this patient of diffuse axonal injury?
So, first of all, again, wait 2 to 3 weeks more. I mean, she's day 14, right? So
Right.
maybe wait 2 weeks more because we know that patients who have some eye opening tend to progress more quickly than those who don't have an eye opening at the end of 2 weeks. That is one thing. Secondly, how to differentiate between vegetative state, very early to differentiate between vegetative state and a minimally conscious state. This differentiation usually happens at 2 to 3 months. But for the sake of discussion, if it is a minimally conscious state, these patients will have some kind of visual recruiting, or they will look at you when you call them. Sometimes you may feel that they are responding to your voice, especially the familiar voices. Sometimes they do have some emotional outbursts, and they seem to be having some purposeful movements. So these are what you see on clinical examination, as opposed to a vegetative state where they will have biological functions, so they will have a sleep wake cycle, but they are not going to follow, or they may not have any eye contact, they may not follow your visual cues, or they may not respond to any of the vocal cues that you are giving them. So I think this is the way you can differentiate between the two states.
Okay, so these are the two MRI images. On your left, as you can see, that it's a brainstem lesion, and on your right, it's a corpus callosal involvement. So that brings me to the next question, the location, whether the location of the lesion uh, does have an impact on the long-term functional prognosis. And can I ask Dr. Suresh this question, please?
Um, to be honest with you, uh, I'm not sure about one's very specific this thing, but yes, if in your corpus callosum is brainstem's areas, if there is a progression, it's gonna lead to a lot of issues. Corpus callosum, because of networking issues, will again lead to a problem. But I personally am not aware. I have not asked that question to myself in a long time, so I'll wait for the other panelists to kind of chip in on that one.
Dr. Gaurav, your inputs, please.
I think yes, uh, the brainstem and corpus callosum both would be very prognostic indicators. I would say, especially with fit in with other things. So the brainstem injuries at the DAI more so than the corpus callosum. I would put that, and putting that with the radiological worsening and serial EEG's dysfunctions would fit into a very bad prognosis.
Okay, so the brainstem lesions are obviously they do have a bad prognosis as compared to the corpus callosal lesion. So now this is a interesting. There is a reactive EEG, and the background electrical activity is actually showing in response to an external stimulus, and that stimulus can be, as has been said by Dr. Urvi ma'am earlier also. The stimulus can be it can be auditory or tactile or even a noxious stimulus, and so that brings me to this particular question to Dr. Gaurav, that what is the role of EEG testing in predicting recovery when your physical examination is not yielding anything at all?
So EEG, as it is becoming a very important tool, it gains much importance. So again, it's not a single EEG. It'll be just like all other investigations. You need a baseline EEG and you need serial EEGs. And if after, let's say, in this case, 3, 4, 5 days down the line, you got nothing coming out of physical activity, along with that, you've got certain 2, 3 bad predictors on the EEG, namely gross slowing, gross burst suppression, generalized suppression, or as you are showing in this EEG, where there is lack of reactivity to actual stimuluses. So all these goes in the favor of bad prognosis. Particularly, missing alpha activity is also comes into this category. So putting into that picture, when you have other things and an EEG that not just on one occasions, on serial occasions, shows you these 2, 3 bad signs, so overall slowing bursts or even continuous epileptic activity that doesn't go away with complete lack of alphas, so that would be really a bad sign.
So how frequently you would like to repeat the EEG?
I think it's not a matter of every day, but once you've looked after all the confounders, so at least couple of EEGs to confirm the same thing.
Is a continuous EEG monitoring more beneficial in these kind of cases?
So continuous is not so beneficial in these cases to prognosticate. It definitely is useful if somebody has the luxury of having it, but they would be more so useful in the usual cases where you are struggling with controlling the epileptic activity. But if you have it and you get to use it and you can prove that there is a 24 hours burst suppression or a continuous epileptic activity all throughout, then you don't need serial EEGs there. Then it is like your continuous EEG monitoring, ECG monitoring, showing you that there is nothing in the brain for 24 hours or more, and then things become much easier for sure.
Okay. So a reactive EEG is actually better because there is a change with stimulation. The amplitude increases, there is more of an alpha activity. So a reactive EEG is definitely, they do have a better prognosis than a non-reactive EEG. So now my question to Dr. Suresh, sir, what is the role of SSEP as a prognostic tool in these kind of situations?
I said again, for any comatose patient you just showed, I think whether it's whatever the etiology of the coma, it's got a prognostic. It's again, as I said, it's if it is if you don't have an evoke potential, it gives you a much uh, a less chance of recovery, but it doesn't make any other difference. So I would say it's again a negative predictive value in the sense like yes, if you are as if your evoke potentials. I haven't again to be honest with you, whether there's any difference between different causes of coma as making this difference, I'm not very sure about that. But overall, in general, I would say the same thing. What you said in the first slide that if your if your SS20 evoke potential cortical stable, nothing is happening in the cortex, very poor prognosis.
Right. So if we just can put it together, because we have already discussed two cases so far. When it comes to cardiac arrest, then this absent N20, as has been shown in our guidelines also, that it is a highly reliable of poor outcome and it is one of the core prognostic tool. But this is not so when it comes to diffuse axonal injury. It is actually less reliable and it is of supportive use only. So in cardiac arrest situations, when you are prognosticating a post cardiac arrest coma, then the absent N20 will be one of the core prognostic tools, but not so when it comes to diffuse axonal injury. This is what evidence shows to us so far. So finally, the question that I'm going to ask to all three of you is, at what point do you shift the conversation session from survival to quality of life. And I'd like to start with Urvi ma'am on this.
Again, I think it will depend on the clinical context. So, if you have an elderly person who has multiple comorbidities and is now has very minimal neuro awakening in that sense, at the end of probably 2 to 3 months, and then these are the patients who now you are going to talk about quality of life rather than survival. So this is what I feel. If there is somebody who is young, like your patient with traumatic brain injury, a 22-year-old, the timeline will definitely change depending on how long the patient's family can pull on, and also what kind of support they can give to the patient in outside in the community, because that is where the entire picture will change. If they say they have no role or they cannot take care of the patient in the community or at home, in a patient who's bedridden, has minimal consciousness, then your questions and the way you counsel the patient's family will definitely change.
Gaurav sir. Dr. Gaurav, your inputs. Suresh sir.
Yeah, I think I start the conversation pretty early. I think the general rule in our part of the world is that uh, taking care of these patients at home is we don't have really good rehab centers in every part of our country. Taking care of them is a challenge, so the family has to be mentally aware that at some point in time you will need to transition the care. And this is a simple rule for an ICU. We say the 1 day of ICU is 7 day of rehab. So if you just multiply that, and you have to give that much amount of time for a patient to get better, as somebody who's been say 30, 40, 50 days in an ICU. I think so. Instead of waiting that long to start that topic, I think we should be very early. The moment we are doing prognosis, I think the quality of life automatically comes there, because it's not only life and death, it's also what is the quality of life. So when we talk about prognosis, it automatically implies that to me.
Okay. So this is my last slide. So talking about the future directions in neuroprognostication, these days we are always talking about AI and machine learning. So there's a lot of data that is coming in, and these are massive, complex, and high-speed data. And there are centers which are integrating all these data, and that is actually augmenting the clinical decision making when it comes to neuroprognostication. And advanced EEGs, we already talked about that continuous EEG monitoring, getting some quantitative data and doing some network level analysis. So centers who are equipped with this, some high volume advanced centers, they are looking into this prospect as well. And biomarkers in the Indian context, as ma'am has said, that NAC is something that we are doing, and not all other markers are so readily available with us. So these are something that are coming up in the near future. So the key takeaways from this discussion is that finally that the 72 to 96 hours rule stays. That is the point when you start doing all those neurological assessment, so that you are not wrong in your prognostication. And multimodal is mandatory. You should not be relying just on one aspect, and you should be mixing up your clinical data with your neuroimaging, with your electrophysiology, with your blood markers, and also everything taken together. And that is how multimodal comes into play. And as we have discussed, that diffuse axonal injury does not always mean defeat. One must give brain that time. So wait and see, and all throughout you have to discuss everything with the family members. So communication is the key. So my final conclusion is that in the world of the comatose patient, we are the translators of a silent language. Our job is to listen to the brain signals and speak the truth with a heart full of hope. Thank you so much to all my panelists, and I hand over
Well
to
said.
Dr. Yash sir, please.
Thank you.
Thank you.
Hi, good evening, everyone. Thank you so much, Sautik, for taking us through this important journey on decision-making things. Uh, One more thing I would like to add is the recent Supreme Court judgment, which is changing long-term perspective and decision towards these patients, and that is going to impact our decisions in critical care and clinical care to patients as well. Moving forward, I'll request Dr. Pratima and Subha Reddy to take us towards a very interesting uh, part of today, which is a pictorial quiz. And trust me, they both have very nicely designed something which has come as a surprise to all our members. Over to you, Pratima and Dr. Subha.
Sir, good evening, sir. I'm welcome to this quiz, and then I'm filling in for Dr. Subbareddy, sir. He had to attend an emergency call to hospital, and I convey apologies on his behalf. Uh, I'm really sorry for his absence. Can we go ahead with the quiz, ma'am?
Yeah, I'll
Yeah.
start. Yeah.
Yeah.
So this is a picture quiz. It's essentially everything is related to coma, obviously, and it'll be more of whatever we discussed today. And it was not planned, but it just fell into every aspect of whatever we had discussed so far. So before any delay, we'll just go ahead. So, this is the question one. You are consulted for a patient in the medical ICU who has slipped into a deep coma. Liver function tests are markedly abnormal. So, identify this classic EEG pattern, and it is characterized by generalized synchronous waveforms occurring at 1.5 to 2.5 hertz. So, you can put in the answer. Uh, this is what I have described the EEG. You can just say if there is any classical finding and differential diagnosis. Unmute and talk or put it in the chat box, please. Are we getting anything in the chat box? Okay, I think everybody is so quiet and they have become comatose. So anyway, so this is a triphasic wave pattern where it is classically associated with hepatic encephalopathy, other metabolic and toxic features also. So that is one form of EEG. And here we can see that there is a triphasic. So ABC, there is a negative upward deflection of A, B is the positive downward deflection, and C is negative upward deflection demonstrating diffuse cerebral disease. So this is the other question. So this patient is presenting with hyponatremia, severe hyponatremia, and the patient has progressed to a comatose stage. Can you just find out what the finding is? It's a very classical finding. So this is something called the piglet sign. So trident also we call it, but piglet is more of something which is classical to the cartoon figure, which we see at the middle of the ponds. Okay, so osmotic demyelination syndrome, and we know that rapid shifts cause this, and there is a destruction of myelin sheaths predominantly in the ponds. So, with the concern of time, I'm just going forward. So please free to interrupt and answer anytime. This is a quiz, obviously. So identify two types of abnormal posturing, which I'm going to show in the next slide. And one type is very typically a structural lesion or damage lower in the brainstem. Please identify and comment. So which one is the most serious? So one is decorticate and one is decerebrate. And decerebrate indicates the damage which is more severe and it is below the level of the red nucleus and it has a worse prognosis. So this is the EEG we discussed today. What is this type of pattern? Can anyone comment?
We are
Thank you
getting an
so.
answer, Pratima, in chat as a burst suppression.
Oh, okay. Yeah. So because I'm sharing that chat, I'm not able to see. Okay. Oh, yeah. It's good. People are answering. So yes, it is burst suppression. Thank you. Thank you for the participation. So this is a burst suppression pattern which we discussed today, and I think we have been clear on that. Usually, it indicates a severe brain stem dysfunction, particularly brain dysfunction. So this is a next. The image is going to be a diffusion weighted imaging sequence of a patient who remains in deep coma 72 hours after surviving a cardiac arrest. What is the radiological sign and diagnosis seen here? So this is called something which I need the answer for. Any comments so far? HIE, yes, but some sign which we say in most of the toxic encephalopathies. Okay, so I'll comment myself. It is called HIE is very right. Thank you, Dr. Hemant Agarwal. So this is this is usually called cortical ribboning. That's how we comment on it, and it denotes a very poor prognosis. And as rightly said, it is HIE. Doctor,
Yes, ma'am.
can you
I'm there.
continue from here? Yeah.
Dr. Munish will continue. Dr. Pratima, I'm Dr. Subarati. Thank you.
Thank you, sir. So we had a 26-year-old male brought with a high-speed motor vehicle accident. He was intubated at scene. After resuscitation and withdrawal of sedation at 48 hours, he fails to regain consciousness. GCS remains 7. MRI shows this following image. So can anyone guess the correct option?
Please comment if it is A, B, C, or D.
Anyone? Shall we go ahead with the answer? Correct.
Somebody has commented B. Yeah,
Yes,
everybody wants
yes.
B.
So now everybody have answered B. I would like to extend this question. Can you tell me which area is affected? Which part of the corpus callosum is affected? Correct.
Has replied Jenu. Dr.
Correct.
Shaikh has replied.
Correct. Is the genu which is affected. So it is the white matter is the one which is affected. And then in case of grade 1, we have this punctate hemorrhages which are seen in more of frontal and temporal lobes. In case of grade 2, it is seen in the genu or the splenium. And then in case if it's a grade 3, then we all know that it's in the brainstem. Mostly involved part is the dorsal midbrain and the pons. Next question, ma'am. Yeah. So this is one of our patient. And then I would like to tell you that this man was our doctor. He was our emergency physician, and he came to us with subarachnoid hemorrhage and post subarachnoid hemorrhage, and then he underwent endovascular aneurysmal coiling. And at day 6 to day 7, he becomes drowsy, and then he has a fluctuation in the weakness. Suddenly, he is able to lift his arm, and then suddenly it drops down. He is not able. So then we have done the TCD. So this is the TCD image showing a flow velocity. Can you identify which vessel is being insonated?
I'm getting responses as C.
Okay. Can anyone tell me about the Lindegard ratio? How do we calculate the Lindegard ratio? Just an extension of a question.
Anybody can unmute and talk also. We don't have that much of participants.
And then I would also like to know that key on based on what features that we have guessed that this is an vasospasm of the middle cerebral artery.
Dr. Jai Prakash has put us 220. Dr. Rohan, flow velocity ratio of intracranial ICA to ECA.
Okay, so I would like to go ahead with the answer if it's okay. So it is the ratio between the mean velocity of the middle cerebral artery and to that of the extracranial ICA. It is the mean velocity of the MCA by mean velocity of the extracranial ICA. And then the we look at the depth and the trajectory of the wave. So it is a positive wave at a depth of 50. So mostly it is corresponds to the middle cerebral artery. Next question.
Yeah.
So I just wanted to give a little bit history about this, and then I wanted to add to the contribution of these two gentlemen. So can you identify them? And they are the ones who have described a state of irreversible coma characterized by absent brainstem reflexes and apnea. Can you identify these two gentlemen?
You can even guess. It won't hurt. Dr. Sheikh has said
Shafi.
C.
Okay. Any other guesses? I think we can guess it by the method of elimination, at least. Like,
Prakash Peri Molaret.
correct.
Okay.
So yeah, so these
answer.
are Pierre Mollaret and Maurice Golan. They both are French physicians, and they have given this term called Le Coma de Passe. That is nothing but a state of irreversible coma in 1959, after which the brain death has come into picture, and then there was always never stopping this on this. So Teasdale and Jennett, they are the ones for the GCS, and Cushing we know. Plum and Poshner are the ones they have written a book on coma. So this is Pierre Mollaret and Maurice Golan. Next, ma'am. So now we have a comatose patient on ventilatory support, undergoes radionuclide cerebral perfusion scintigraphy. This image demonstrates what?
Actually, it's very classic and very nice.
Okay, somebody is able to answer the option.
Dr. Prajakta says A.
Okay, I have a lot
Dr.
of
Rohan
answers
A.
coming as A. Can anyone
So
tell the
Dr.
sign,
Hemant
please?
A.
Can anyone tell what is the name of this sign, please?
Empty skull sign by Dr. Prajakta. So that is this is a very classical sign, very nice picture actually.
Okay. Yes, it's the hot nose sign. And then with this question also, I would like to say that there are only 4 ancillary tests, and then the 2 ancillary tests which we have been uh, relying on for a long period of time, that is the EEG as well as the CT angiogram, both are not a part of ancillary tests anymore. There are only 4 ancillary tests for brain dead declaration. So first being the DSA, which is the gold standard. Then we have the radionuclide angiography. Then we have the radionuclide perfusion scintigraphy. And in case of adults, it is the transcranial Doppler. So CT angiogram as well as EEG are not ancillary tests anymore, because CT angiogram has got an fallacy that it has got lot of false negatives, because the raised intracranial pressure can cause the compression of the veins, which will lead to filling of the vessels and which will give us a false negative measure. So CT angiogram is also not there. So and then EEG, we all know that it's a measure of cortical activity rather than brainstem activity. Next question, ma'am.
This is the last one.
This is the last question. A 3-year-old child is brought to emergency department following unwitnessed event. The child is unresponsive. Can you guess what it is? What and why?
A. Dr. Sheikh. Dr. Jayaprakash A. Dr. Shruti says D.
The option will get easier. Now, this patient comes with history of drowning.
He says reversal sign. Dr. Jay Prakash says reversal sign.
Yes, sir. It is. You can call that also. It is a reversal sign. So yeah, the option is A. So it is diffuse cerebral edema due to hypoxic ischemic
Dr.
injury. So
Rohan says A. Okay.
correct. So this is nothing but the white cerebellar sign because the cerebral hemispheres are much more sensitive to hypoxia compared to that of the cerebellum. And there is also a preferentially we have some posterior circulation flow is maintained before they go into the hypoxic damage. So this is the white cerebellum sign.
So thank you. That was very nice participation. Somebody is talking. Okay. Fine. I
Thank
think we
you.
have come to the end of
Thank you.
this.
Yeah, thank you. It was a wonderful session in terms of very pertinent questions coming up, and the responses were also very nice. So, Dr. Zirpe sir, you want to say concluding remarks?
So Dr. Shrishti will take the question answers and summary of the day.
Great. Right. Over to you, Srishti, then.
Ramesh, sir. Zirpe, sir, please, sir. We can give the vote of thanks and for sir. Okay. So on behalf of SNCC, I'd like to thank all the faculty members. It was a very crisp presentation, short, crisp, loud and clear. The message was clear. Do a detailed workup, do a dynamic workup, and prognosticate with surety, with objectivity. And I thank all of you for sparing your valuable time. I also like to thank SNCC and the office staff for the continuous support. Thanks delegates for joining. Thank you all. Good day.
Thank you, everyone.
Thank
Good
you
day.
very much.
Thank
Thank
you.
you. I
The
think there is a
YouTube link has
message
been
from
shared in
Dr.
the group.
Vipul who wants to be a member.